was there. So here we go with technology again. We've got Dr. Perry Hoffman, and the idea here, ladies and gentlemen, is you're going to see Dr. Hoffman on this screen here, the smaller screen at the front, and you're actually going to see her presentation at the back here. We have a friend behind the stage, Celeste, who has done her best to morph into Dr. Perry Hoffman's brain and work out exactly when that click is going to need to happen when Dr. Hoffman's speaking. And I reckon that's going to be pretty special, isn't it? Yeah, brilliant. So what's going to happen here is that we're going to watch both at the same time because we're really clever. Now, just a little bit about Dr. Hoffman. She's the president of the National Education Alliance for Borderline Personality Disorder. She has been highly successful in promoting awareness and positive culture change in the USA, which has resulted in increased services, resources, and access to the treatment. Ladies and gentlemen, can I introduce via the marvels of technology, Dr. Perry Hoffman. She won't hear you clap, but it might make you feel better.
Hello and good morning from New York. It's just a pleasure to be here, and I want to thank the conference organizers for making this possible. I wish I could be there in person. I hope next year, if you do another conference for your second annual BPD Awareness Day, that you invite me, and I'll make sure to make it a priority in my calendar. I think it's terrific that Australia has now recognized BPD in such a national way, and again, to be a part of this is very special to me, so thank you to everybody. I'm not sure how I was introduced or how this DVD was introduced, so let me just tell you a little bit about myself. As you know, my name is Perry Hoffman, and I am a co-founder and president of the National Education Alliance for Borderline Personality Disorder. When I first started my career, I worked with relatives of individuals who had schizophrenia, and I was just really so taken back by the pain and suffering, both for the individual with the disorder and also for their family members. When I then went over to work with families who had a relative with BPD, I was even more struck by the pain and the suffering of everybody in the family. And we think of schizophrenia more as the prototype of mental illness. So to think that maybe BPD is even more painful for caregivers, for the individuals, I think it's a food for thought. But as I start my presentation, I want to also share with you some data that does support that. The name of my presentation today is called Family Matters. And what Family Matters means is from two different perspectives. It means family matters, meaning that families and their involvement matters, and also family matters, meaning family issues. So I'm going to present it from both those perspectives and also let you know how our national organization evolved and how we got to where we are today. And hopefully maybe people in Australia will want to join us and really make this an international effort. I'm going to try to remind myself to say, change slide please, so that whoever is monitoring this video can also try to put the slides in sync. So I thank you. So family matters, different perspectives, different perceptions. What makes this disorder so hard for families? Well, we can first look at Time Magazine. Time Magazine is one of our most famous weekly journals. I'm sure you probably have seen copies of it here at times. And about 2 years ago, they had an article on borderline personality disorder. And if you can see the arrow, you can see what the byline was. Borderline personality, the disorder that doctors fear the most. Well, perhaps this says it all, and perhaps this is exactly what makes things so difficult, as it's hard to treat for professionals, it's also hard for family members, and yet we know there's a lot of hope. So if there's anything you do remember from this presentation, please do remember there's hope and people do get better. Change slide, please. Now, what makes it so stressful? Well, let's first look at what is stressful for mental health professionals. This was a study that was done in 1988 by Hoffman and colleagues, where they identified that suicide attempts, threats of suicide, and patient anger were the three most difficult things for professionals to work with. And lo and behold, this is certainly what the BPD community deals with. So if this is stressful for professionals, you can only imagine what it's like for family members. And actually what we did was we did a study because we wanted to see what is most stressful and what is the stress like for family members and how does it compare with Axis 1 diagnoses or people who primarily have schizophrenia. So we did a survey called the Family Perspective Survey. These are my colleagues who did it with me. We had family members who had a relative with schizophrenia fill out a form with several questionnaires, and then the same questionnaire was used for families who have a relative with borderline personality disorder. And this is the data that came from this survey. What we found was, and the red boxes are for Axis 1, primarily schizophrenia, and the yellow boxes are for borderline personality disorder individuals' families. What we found was the grief was higher in the borderline family, higher in depression, and higher in burden. So on all these three levels and measures of distress, we see that families of borderline patients were higher on all three measures. Why is borderline personality disorder more stressful? Well, first of all, it's a disorder that exists in the context of relationships, which means that the symptoms happen in surrounding a relationship. So for example, if someone who seems to have borderline personality disorder went then to live on an island all by themselves, obviously they'd have other problems being so isolated. But the point being is that they wouldn't necessarily look borderline because they would not have a relationship that they interface with where the symptoms are a problem. I'm sure in this conference today you're going to review the symptoms. I'm just going to quickly go over them and just highlight the key words in each of the 9 because I want you, as I'm saying them, to think about how this impacts relationships. So this is borderline personality disorder, DSM-4 slide. So we first have abandonment, unstable and intense interpersonal relationships, identity disturbance, impulsivity, change slide please, suicidal behavior, affective instability, emptiness, intense anger, and paranoid ideation. 7 of those 9 impact relationships, and maybe perhaps later in the discussion period of this conference you'll have an opportunity to look more at it. Change slide please. So how patients and families see each other. This is another piece of information that we got from data that also highlights why things might be so difficult in relationships. And what we did here was we took an assessment called the NEOPI, which measures 5 factors of personality. And we had the patient and their family member each fill out the questionnaire twice. One time they filled it out on themselves, so the patient filled it out on themselves, family member filled it out on themselves. The second time they filled it out on the other person. So the patient filled it out on their family member and the family member filled it out on themselves. And this is what we found from the data. That when we looked at how patients were perceived, okay, in terms of anxiety, hostility, depression, self-consciousness, impulsivity, and vulnerability, that the parents, or these were primarily parents actually, the parents and the patients were pretty much in sync with how they saw the patient, how the patient saw themselves, and how their family members saw them. This is contrary to when we look at the perceptions of relatives. When we look at how relatives rated themselves and how how the person with BPD rated their relatives, we found that there were discrepancies. So the patient rated their family member higher on anxiety, hostility, depression, self-consciousness, impulsiveness, and vulnerability. So you can imagine if people perceive each other in different ways, it is a source of conflict and friction. Change slide, please. What we then said was, all right, so maybe partially what needs to happen is that family members need to have knowledge. Knowledge is good, knowledge builds awareness. And so we sought out family members who really are desperate for knowledge, and we did some assessments on their level of knowledge and then tried to see how it correlated with their levels of distress. Change slide, please. And this is the article that came from this study. Family members' knowledge about borderline personality disorder, correspondence with their levels of depression, burden, distress, and expressed emotion. What we found was that the more educated, the more informed, not educated in terms of years of college, but the more informed on borderline personality, the more knowledge they had on the disorder, the more hostile they were. The more information they had, the more burdensome they were. More information, the more subjective burden. The more information, the more depressed they were, and the more information, the higher their brief symptom inventory, which talked about their own well-being. So what we realized was that when family members had just knowledge, it really didn't help. It actually may be a deterrent. And I have to say, and I'm sure those of you who know the internet well know that primarily what is on the internet, it does not give a lot of hope. Over 50% of the family members who were in this study got their information from the internet. So what we need to know is that the internet needs modification. We need to let family members know that there's hope, and we need to perhaps also, as you'll see in some later data, also give them more than just knowledge. This is actually what some of the burden constructs were, and I think it's important and interesting to see. They worry about the patient's future. They worry about the intensity of family friction. They worry about their own ability to concentrate. They worry about the upset in the household routine, reduced leisure time, fear that their own behavior would make the patient worse, and worried about how much the patient changed. So where do families fit into the picture? If they, in fact, at times their negativity increases if they get involved on some level, what does this say? Well, let's first look at something that Dr. Anthony Bateman wrote for the endorsement of the book that Dr. John Gunderson and I co-edited that was published in 2005, Understanding and Treating Borderline Personality Disorder. Families, friends, and caregivers of people with borderline personality disorder have long been neglected by mental health professionals. Blamed, censured, stigmatized, they have been relegated to the anteroom of treatment, rarely being considered as a positive force to be harnessed for effective intervention. But does that mean families, what shall we do with them? Shall we keep them in the back rooms and not be involved? Actually not. There's an importance of family members, a very, very great importance in them. And this comes when we look at the construct of expressed emotion. Now, expressed emotion is a construct that was designed in the 1960s in England, actually, and it was started with patients' relatives with schizophrenia. What they did was there's a semi-structured interview where family members' attitudes and beliefs about the patient are questioned, audio taped, and then coded for later ratings. And what it was found was that with families with a relative with schizophrenia, as I said, then subsequently depression was tested, eating disorders, alcoholism, a lot of different other psychiatric disorders, it was found that actually most of the findings were similar, that the more critical the family member was, the more hostile they were, and the more emotionally over-involved they were with the patient, the less well the patient fared over a one-year course of the illness. So we did this now as the first study done with borderline personality disorder patients and their families. And we interviewed 35 family members. What we found, which we think was very interesting, that critical comments did not predict one-year patient outcome. Didn't matter how critical the family member was, nor did expressed hostility predict one-year patient outcome. We're not saying that we should be critical or hostile to patients, but for some reason this doesn't impact them in the way it does other disorders. What we did find, though, however, that emotional over-involvement really did impact patients and actually impact them in a positive way, meaning that the more emotionally over-involved, and Dr. Jill Hooley at Harvard, who I did the study with, we both agreed, and that's why the word over is in quotes, to remove the word over because it's really emotional involvement. And the more emotionally involved a family member is with their relative, the better the relative fares. Of course, there are ways to be emotionally involved that are healthy, and some of that comes later in our family programs. So we know that emotional involvement is good for the patient. We know families make a difference, okay? And that's what we want to shift to now. And we have to find the dialectic when we know that some of this is hard for families, very stressful, creates added distress in their life. We need to find the dialectic to help the family stay the course with their relative, because that's who is often there always in the end. So let me now start to talk about the National Education Alliance for Borderline Personality Disorder. In 2001, I had the good fortune to be at a wonderful conference at the Rockefeller University in New York, and all the top researchers were there, and there were a few of us that were invited, very lucky to hear the presentations, and we heard the most wonderful, the most current research on borderline personality disorder. And as I was sitting there, I was thinking, this is terrific, all this new data, but when will family members hear about it? And those of you who are researchers know how long it takes to first compile the data, for it to get written up, for it to get submitted to a journal, for it to get approved by a journal, and then out in publication. And sometimes it takes several years. So with that in mind, and also the fact that the National Alliance on Mental Illness, which is the United States voice on mental illness, I was thinking there's just not a voice here for our disorder, because NAMI, which is the National Alliance on Mental Illness, did not take BPD under its mission umbrella. So I was at this meeting, was fortunate enough to meet some family members, and then there were some other family members I knew from my work and some consumers, and I suggested that we all have a meeting within the next month. And we did. We met on August 20th, 2001 in my office, and we started our not-for-profit organization. We call it, as many of you might know, the National Education Alliance for Borderline Personality Disorder, or more often called NEA-BPD. We're chartered by the Board of Regents of the State of New York. We're co-founded by 4 family members, 2 consumers, and 1 mental health professional. We're an all-volunteer organization, which means that nobody gets paid for the time that they do for this organization. We've never written out a paycheck to anybody. And that all funding and donations directly go to support our programs. Change slide, please. So what happened at our first meeting? Well, we identified what we wanted to cover, and we drew up an agenda, and these were the things that we sort of organized our thinking around. That there was a lack of information and misinformation on borderline personality disorder. That the stress and distress of family members was very high. That there was importance of the involvement of family members. There is a clear lack of awareness of the disorder. There is a deep sense of hopelessness, and the stigma goes beyond any other mental illness. There have been articles written on other mental illnesses, and there have been actually some campaigns in the United States to highlight the stigma in mental illness, and borderline personality disorder is never mentioned. And in fact, what's happened on some interviews is it's not mentioned, but brought up maybe by an interviewer, and then someone says, oh, that's a hopeless disorder. Well, I'm hoping that all of you in this room here today know, as we know, so many of us now more know, that in fact this is a very treatable disorder. So we designed and defined what our mission statement is. Change slide, please. And the mission of the National Education Alliance for Borderline Personality Disorder is to raise public awareness, provide education, promote research on borderline personality disorder, and enhance the quality of life of those affected by this serious mental illness. And just a little sort of side note is that you see that I'm wearing a ladybug pin today, and my glass of water has a ladybug on it. And the reason that I'm so attached to ladybugs now is that day when we had our meeting, one of us went to the cafeteria to get coffee, someone else went to the ladies' room, someone else ran down to buy some more pencils, whatever. But each one of us, when we came back in and rejoined the meeting, said, guess what I saw? I saw a ladybug. All of us in that meeting that day, at some point in time in that day, saw a ladybug. So we've now adopted this as our sort of signal of hope, and we hope that maybe that might be something you might think of doing, taking the ladybug and showing that this is a symbol of hope. What we then decided was that we wanted to serve different groups in the BPD community, and the focus is professionals, family members and sufferers, and government agencies. So what I'm going to do now is walk you through some of the things that we have done with these different stakeholder groups. The first we felt was the need to inform professionals. And I'll just give you a little caveat of something that personally happened on Friday to me. I was working with a woman who has borderline personality disorder, and I was looking for a referral for someone who could do couples therapy with this patient and her husband. So someone gave me a gentleman's name. I emailed him to ask him if he had time in his practice because I had heard such nice things about him, and he emailed back. He said, "Oh, I see the signature at the end of your email. It says that you're president of a national organization for borderline personality disorder." He said, "Well, you know," and this was all in an email. He said, "You know how I know when I'm with a borderline patient? When I want to slap them." I thought, well, there's one referral I'm not going to make. And unfortunately, I think that his sentiment is all too common for professionals. So what we have tried to do and continue to do is to educate professionals, and for many of them, re-educate them. And this is how we focused it. We've done about 40 conferences. We've been very lucky to get 2 grants from the National Institute of Mental Health to fund 8 conferences, and we've been fortunate to spin those 8 sort of buckets of money for conferences into 40 conferences. We've designed a website specifically for professionals, and we hope you'll join it. It's called bpdforum.com. On that forum, we have over 100 audio and video tapes of our conferences going back to about 2005, and we hope to get up the earlier ones as well. We run courses. We've done a residency workshop at the American Psychiatric Association convention. We did it 2 years ago. We didn't do it last year because they were just too far away from us, but we submitted and got accepted to do it again. And what this is that for 2 days, 2 mornings, we meet just with residents who are at the American Psychiatric Association. And my co-presenters are Dr. John Oldham, who's president of the American Psychiatric Association, Ken Silk, who many of you who are doing medications know, he's one of the leading pharmacologists, Dr. Brian Palmer, who's at the Mayo Clinic, and then I'm fortunate enough to present from a family and consumer perspective, and also with Jim Hall, who is a family member and has a daughter with the disorder. So we've started courses for that. We've also just completed with Dr. John Gunderson at McLean Hospital, Dr. Brian Palmer, and Dr. Lois Choi Kane, online course for psychiatrists that will provide CME credits. I think it's an excellent one. We hope to get it out within the next 3 months, so I hope, even if you're not a psychiatrist, that you'll look for it and learn from the course. We've also done a textbook, and it's Borderline Personality Disorder, Meeting the Challenges to Successful Treatment. That's so far what we've done for professionals. And the need to inform public awareness. This is what we're trying to do in the public arena. We worked with NAMI, the National Alliance on Mental Illness, to encourage them to make BPD a priority population, and that happened in 2006. And what's so nice now is that we work with NAMI very closely. When there's anything around borderline personality disorder, they turn to us, and they've been wonderful. They redesigned their brochure. They invite us to come speak at conferences, and it's really been a win-win situation. We also have worked on public service announcement. We've had one running for about a year. And then I'm not so sure because, of course, in America, we watch our sports fans, our sports people probably more closely than you do. But we were very fortunate July 31st to have Brandon Marshall, who was a wide receiver for the Miami Dolphins, make a public announcement that he has borderline personality disorder. So actually last week, last Monday, September 20th, I think, I went down to Miami for a few hours, and we shot a public service announcement where he identifies that he has the disorder. His mission is to educate people and to also say that there's a lot of hope for people with the disorder. So that's one thing that we've also been working on. We also work closely with the National Institute of Mental Health, which is also called NIMH. Last year, We were able to get Marsha Linehan to come last October and to do a presentation, of course, when Marsha Linehan comes, who's the creator of DBT. When she comes, there's standing room only. More recently, we starting work with SAMHSA, which is our services branch of the government. NIMH, the National Institute of Mental Health, is our research branch. SAMHSA is our service branch. So they were requested by Congress for a report on the disorder. They put together an outstanding report. You should go on their website, which just put in the SAMSHA and it should come up. And since then, we've had a meeting with them and with NAMI. And in November, we're very excited about this. We have a federal partners meeting, which means that all different branches of people interested in mental illness, the NIMH, SAMHSA, NAMI, and NEA BPD will be meeting for a day to try to come up with some initiatives and action points to do for this disorder. Marsha Linehan will be there, John Oldham, John Gunderson, and some other key players. So we're very excited about that and can keep you informed, because I think as you move along with what you're doing, that to see what our government's supporting might be helpful to you. We've also worked towards building awareness with Congress. We've had 2 congressional briefings, and then we're very happy to say that our awareness officially got stamped in House Resolution 1005 in 2008, where our Congress decided to declare May as Borderline Personality Disorder Awareness Month. And I'll read to you, next slide please, what it says. House Resolution 1005, May is BPD Awareness Month. Whereas the National Education Alliance for Borderline Personality Disorder and the National Alliance on Mental Illness support the designation of Borderline Personality Disorder Awareness Month as a means to educate our nation about this disorder, the needs of those suffering from it, and its consequences. Resolved that the House of Representatives support the goals and ideals of Borderline Personality Disorder Awareness Month. So we hope that your government maybe will, or perhaps has already done that with this wonderful day and conference that you have. Now I want to shift over for the need to inform family members. New slide, please. Let you catch up. Okay, so now we're on a slide with a number of 6 points. And now we're on to action for family members. These are the conferences that I talked about before, 40 conferences. At all of our conferences, we always have family members, consumers, professionals, anybody interested in learning about the disorder. And we have just found it an amazing experience to do this. And of course, no surprise, the people always rate highest on our evaluations are our family members and our consumers, because they do tell the heart of what it's like to have someone with the disorder. We have our website where we have the most current information with audio tapes and videotapes, and our website is www.borderlinepersonalitydisorder.com. We have also done call-in seminars over the years. This fall we started a regular Sunday night call-in, where every Sunday, and I'll go through the schedule just so you can get a sense of what we talk about. Every Sunday people can call in for free and listen to a top professional talking about the disorder. We also have a book out that Dr. John Gunderson and I co-edited, and I referred to that before when I read you Dr. Anthony Bateman's endorsement. We've put together a video series, and it's been researched now, and this is called Living with Borderline Personality Disorder. It's by Dawkins Productions, and also if you're interested in more information on that, that's also on our website. And our what would we say, our calling card, the heart of what we do are our Family Connections programs, and I'll go a little bit into that. There are Family Connections and Teleconnections. Just want to close out all of this and just quickly go through our phone call-in series. We've grouped them in according to families and professionals, but anybody can sign on for any of them. We just wanted to make it a little clearer for people what they might find of more interest. We had our first call last week. We had well over 100, 150 people on that call, and each day I get more requests to sign on. So we're hoping that this is something that's of value. The first week we did, which was September 18th, and I'll just run down it, skills for effective family communication. We'll then do something on our family connections, must-have skills, something also on informing patients and family members of the diagnosis. Those of you at all in the field, whether it be that you're getting treatment or you're a professional or a family member, know that oftentimes people are not given the diagnosis. And if you're not given a diagnosis, how can you get treatment? For professionals, we're specifically gearing things to medication, benefits and liabilities, safety plan, a new intervention for suicidal patients, DBT, the latest information, mentalization, review and report from the annual Is It DBT meeting, which is held in November, transference focus therapy or TFP, and research where we were and where we are going. So I think that these are all wonderful call-ins. If there's any way that you can call in, please feel free to. Just send an email to neabpd@aol.com. But make sure that your service provider allows you to have free calls, otherwise you might get a big bill on your phone bill. So now I'd like to turn to the program that we are using to educate family members. Remember back to the data that I showed you before, that information just doesn't help family members. So what we did was we put together a program. It's, change slide please. It's a 12-week multiple family group program. It's community-based, which means it's done out in the community wherever we can get free space. We don't pay for anything. We don't need to. NAMI gives us space. We get spaces in hospitals, churches, synagogues. It's for family members only, parents, partners, spouses, adults, children. It's organized around DBT skills and strategies. There's a manual. It's standardized. It's a semi-structured manual because people sometimes bring in some of their own little extras as leaders. It's primarily run by family members who come in for a weekend and are trained by our organization how to do the course. And the very important mandate is that there is no charge for the course, so people come and don't pay a fee. We do ask them to make a donation or contribute to the organization if they can, but if they can't, that's not a problem. More recently, professionals have asked to become trained in the course, and we do let them come, but they have to sign on to say that they will not charge for the course. I know in Australia, you're fortunate it's a little different. You don't have to worry about that, but in the United States, we do. So this is the format of our course. We have trained some people here. Dr. Roy Kravitz is among them. So we're hoping also to be able to bring the program to Australia, and if you all feel that there's a need, if somebody could contact me, we could see how we could arrange that, maybe bringing some trainers there to do the training. The goals of our Family Connections program are to provide the most current information and research, to teach coping skills, strategies, individual skills or mini DBT skills, and family skills, and to help develop a social support network around BPD issues. Our course modules are 6. First we do an introduction and orientation, and this is where families get to know each other. And I must say, because I've run the course as well myself, is that family members just sitting in the room is therapeutic for them. Some come in with their eyes down, very uncomfortable to talk, and then by the end of the group you can't even get them to stop. I often joke, our leaders often tell me, yes, we say that the course is 2 hours a week. Well, it's not, because it continues in the parking lot. Afterwards, families hang out and talk because they have such a bond of this common experience that they've had. We do psychoeducation, where we give the basic information about the disorder, and because we run these conferences, we have access to the most recent research, so we try to update our information as often as possible. Relationship for mindfulness, which is how to be in relationships. We talk about family environments. We talk about the concept of validation, and the last is problem management. So these are the 6 modules. They happen over a 12-week period. Doesn't mean that they each take 2 weeks. There's a fluidity in how the leaders do things. And then we researched this after we got it started and piloted it just to see how the skills were adapted. We did a research study, and we had 44 participants, 4 sites. There are typically 10 to 12 people in the group. We found the retention rate, which meant what percentage of people remained in the group. We found that very high, 88%. What we were targeting were similar to what you saw in that survey. We were targeting grief, burden, depression, and then a construct of empowerment. And the findings that I'm going to share with you now were replicated 3 times. Change slides, please. The first is we saw a change in grief. And if you see that there are 3 different boxes here, it's pre, post, and then follow-up. So after the course, which is the middle box, that's where the change in grief went. And then 3 months post and finishing the group, the grief continued to go down. So we find that the skills continue to work. Change in distress or depression, same kind of thing. You see where it started with the orange box, then the middle box is right when the group ended, and then the green box at the bottom is the 3-month follow-up. Burden, similar too. Change from pre to post, and then 3-month follow-up. Change in mastery, and this is where there was something that was in the skills that empowered parents to be able to feel more able to cope. Just as an aside, and I don't have the slide here, is that I show a slide when I do some presentations where it's 2 parents sitting on a couch and their adult child comes walking into the room. The adult child is sort of designated to be a duck. To father and says, we are absolutely, positively not driving him south this winter. But that's what families feel they're doing. They're doing things that are so out of bounds of what's in the norm of a relationship that it's like taking a duck and driving him to Florida and not expecting him to be able to fly. So what we found was that family members changed in their ability to manage things, and that also continued after the post and in the 3-month follow-up. We found, change slide please. We found that our Family Connections program was at such demand that we haven't been able to keep up with it, and we still haven't. But what we designed was, because we do not have leaders trained in all over the country, we have about 150 leaders trained at this point, that we decided to test market it by doing it by telephone. And actually, we have found that to be very good. It's still 12-week. It's a conference call format, still have 10 to 12 participants, same Family Connections leaders, and we have a secure page on our site where group members each week load down the lecture that's going to happen that week. So it is something to consider. I think in Australia it's probably something very much to consider given how big your country is. So maybe at some point someone wants to take on that task, and we'd love to help you do it. So what's the organizational template of us? Well, we first decided what was the structure of our organization. So for anybody who's interested in, doing something like NEA BPD, we'd love to have an NEA BPD in Australia. We would be happy to help you do it. This is sort of the organizational template. We are a nonprofit organization. That was what we decided that first day. That we defined our mission and our leadership, and so there were 8 of us in the room, and we decided who would take what positions, and we had a president, vice president, secretary, treasurer, and then since then we have spun out more things for our board members to do, and now I think on our board we have about 15 people. So the course of action was, then, at that day, we decided we needed a scientific advisory board, and we have about 30 names on that. Most of the top people in this country on that scientific advisory board. We decided we were going to do workshops and conferences. As you've seen, we've done 40. We decided to make our website very important. We wanted to be a source of information. We have the largest media library probably in the world with all of our tapes. We decided we wanted to do a a program for families, which is Family Connections and Teleconnections. We have an information packet, and that we also try to get people connected, not with referrals, we don't do that, but with resources, where there are resources in the country to get them connected together. So that's been our organizational template. The key adapters who have joined to help NEA BPD the collaborations have been through National Institute of Mental Health grants, NARSAD, which is the largest private funder of mental health research in the United States, and again, NAMI, the National Alliance on Mental Illness. With our professionals, we do it through our scientific advisory board, our conference presenters, none of whom get paid. They come at their own choice to help educate the BPD community, and we have our chapter authors who have contributed also at no cost to us. What our families are doing is we have hub captains in some key cities. In Houston, we have a wonderful family who not only stayed in Houston, but then went out to all over Texas, and they've been incredible. They've been the driving force with NAMI, so we're so appreciative that they've taken that on. In Los Angeles, we have an incredible group. I actually just flew in this morning from Los Angeles, where we did what we call a meet and greet, where we invite people to the community to come in and to hear about what we're doing, learn about some programs, and it was an absolutely wonderful afternoon. In Atlanta, we have a group of people. We're actually hosting a conference in Atlanta November 4th, and then in New York City, we also have a strong group of family people, NEA BPD and Family Connections leaders. So we're very, very pleased how families have come together to help us promote more work that we can do. And for our sufferers, consumers, we have lots of different names, but our individuals who have borderline personality disorder, we've been actually and actively trying to help them get to break the silence. It's going to be through our consumers that we're going to educate the community and the public at large the best. So I think you might even be ahead of us on that, but we're working hard. The stigma with the disorder in our country, I can speak for, is really so high that it really makes people not want to come out. So I thank you for this. I hope that I've provided something that will give you more food for thought, what can be done with families. I look forward to also maybe getting emails from you that you can tell me, ask me some questions, give me some direction about how we may be able to help you. My email address is phdhoffman@aol.com, and as you see, it's also on the slide here. So again, thank you to the conference organizers for inviting me. I hope that for your second awareness day that you'll invite me, and I'll make sure to make it a priority on my calendar. Thank you again.
Okay, thank you.